I'm here with Terry Kim, the treasurer of ASCRS. Terry, I use intraoperative aberrometry, but I when I think of it, I think of my post-LASIK patients. I think about my toric patients, and that's all the thinking that I do. Mm-hmm. But I understand that it has utility in atypical cataracts. What does that mean?
Yes, that's what we presented today, was the benefit of using aura in these quote-unquote atypical scenarios that have not been published in the peer-reviewed literature yet, and specifically that alludes to the high myope patients and the high hyperope patients, as well as the RK patients, which many initially thought aura would not play a role, but we're finding that you can get measurements in these patients with 4, 8, 16, even 32 incision RK patients that can prove of benefit, because we all know those can be very difficult to fine-tune.
So I've used aura. How difficult is it? I mean, aura can be challenging even on regular cataract patients if there's anything going on with the ocular surface, and by definition, all these patients have got things going on with the ocular surface. Right. How challenging is it to get a repeatable reading that I can then use?
So actually, I found that the 4, 8 incision, even the 16 incision RK patients can get reliable readings. And what I try to get is 3 readings in a row that are repeatable and that show consistent measurements. I think the critical thing there is how far their RK incisions extend into the central axis. And if you have at least a 3 to 4 millimeter clear zone, because they all differ according to which technique was used and how far they went into the center cornea, you can still have a fairly good central corneal zone that's clear of RK incisions that you can get good reliable measurements from. It's not all these patients, but like you alluded to, anything helps in these scenarios.
Yeah, no, certainly. It sort of narrowed down that probability envelope, if an envelope can be narrowed. Right. So the other group who are refractively challenging are patients with completely normal-looking eyes and beautiful corneas, but axial lengths that are like 3 or 4 yards long. And there are calculation formulas, the Barretts, the Hill radial base function formula that are beneficial. But does aura have a role here in helping me choose the appropriate implant lens power?
I think so. There's only, to my knowledge, one peer-reviewed study published in the Journal of Cataract and Refractive Surgery by Darren Hill and his colleagues looking at the benefit of aura in these high myope patients defined as axial length greater than 25. So in their retrospective study of roughly over 50 eyes, they compared the results of using aura compared to pre-op biometry in patients who had, the Hill RBF, the Wankook optimized, the Barrett, the Holiday 1 and 2, and they did find that in that patient population there was a benefit in terms of higher accuracy in patients that were done with aura, and as superior to the other formulas and as effective as the Wankook optimized formula for Holiday 1. Now what we did at Duke is we also did a retrospective study specifically looking at that population in addition to the high hyperopes defined as an axial length of less than 22, as well as the RK patients. And this was a retrospective study where we used the pre-op measurements of either a universal 2 for those high hyperope, high myope patients, or the True K formula, which is available. These are Barrett's formulas. And we found that, number one, there were a very high percentage of patients that underwent an IOL power change. For the high hyperopes, you ended up usually picking a higher IOL power. For the high hyperopes, you ended up picking up usually a lower IOL power. And for the RK patients, usually a higher IOL power. If we looked at the mean absolute error of these pre-op biometry compared to the aura, we are finding a statistically significant difference between that biometry versus aura group for the high myopes and hyperopes and the RK patients in our analysis right now. This is an interim analysis. And the percentage of patients that get within half a diopter, which we all know we're trying to do in terms of improving our refractive goals for cataract surgery, were higher for the aura group for all 3 patient groups. So I do think there's going to be a benefit of using this in this patient population, especially when you talk about that 30, 32 millimeter axial length, where you're now using, let's say, an MA60 MA lens, a very low-powered lens that's not going to be able to go through a Wankook formula that's optimized. So again, getting some guidance in these patient populations, I think, it's better than having no information.
So let me ask this: in the context of this study, were the aura readings pseudophakic readings too, or just the aphakic readings?
Just the aphakic readings.
Yeah, and so the reason that I ask is that one has to put a great deal of faith, some of which I think is probably not founded, on the estimated lens position for pseudophakic cases for very, very long eyes. You really don't know what's representative.
Correct. Yeah, I think you're correct there. I typically do not do a post measurement after the IOL is in, but I think there is somewhat of a learning curve in terms of learning when to trust your aura reading versus going with biometry. And the cases where, and they've only been a few, where I've had some surprises, are patients who have irregular corneas, scarring, some kind of opacity that may interfere with the reading. Unfortunately, the aura at this stage does not tell you how good your reading is when you get it in terms of accuracy. So you're forced to use what it tells you, but when it does tell you that measurement, you have to kind of use some clinical judgment there in terms of whether to trust that measurement.
Terry, we were talking off camera about a particular vulnerability. Can I get you to spell it out to us?
So we realized in a patient case scenario, a patient who was undergoing routine cataract surgery with a low-ad multifocal lens, that was a fairly routine case. Both the Holiday and the Barretts showed a 21.5 diopter IOL power for this patient who desired to have a multifocal lens. However, on the aura reading, it came out to be a diopter and a half less. And so we were confused after multiple measurements, consistently coming out with a diopter and a half difference. So I looked back on the LensStar printout and noticed that, number one, the white-to-white measurements on this patient were not symmetric between the two eyes, and also they were very small, like 8.5 millimeters for that right eye. When I looked back on the patient's cornea under the microscope, I saw that the patient had very dense arcus senilis. So just for curiosity's sake, I measured a white-to-white manually with some calipers, put that number, which ended up being 11 millimeters, back into the aura reading, and all of a sudden, the measurements coincided. So I think this is an important tool, because if you look at what aura uses to make that calculation, it's based on what's called the wave-tech factor, which uses 4 regression coefficients: patient's axial length, Ks, but also uses the white-to-white measurement. So it stresses the importance of having not only correct measurements, because we're all transposing this manually into the aura reading, but pay attention to, if you get an erroneous reading, see if the patient has dense arcus, which can throw off your white-to-white.
That is so interesting.
Yeah.
That is so interesting, and it makes sense. And it's exactly the sort of thing that I never would have thought of. Terry, I want to thank you very much for bringing this compelling topic to us, for making it also very clear, and as always, for being so very generous with your time with us today.
Always a pleasure, Josh. Thanks for having me.